So our presentation today is really going to focus on some of those perspectives of naloxone. I want to first talk very briefly about how naloxone works, just to make sure that from an expectation standpoint, we're relatively clear. Then we're going to take a look at perspectives, both from healthcare professionals as well as from individuals who do use opioids. And then we're going to look at what may happen as a result of those perspectives. So what impact could those perspectives potentially have on treatment of patients who have opioid use disorder? So that was my question that I'm asking you to answer. I'll take a peek at it here at the end, but you're absolutely able to answer that anonymously. So naloxone, that's going to be our focus, the only thing I'm talking about today in terms of medications. It's approved by the FDA for emergency treatment of suspected or known opioid overdose. It works by blocking the opioid receptor. So in our brain, we have all of these opioid receptors. There are natural compounds that work on these receptors. They help prevent signals from being sent. It prevents other neurons from sending additional messages, and that's how it really assists with some of the actions that we use them for, specifically for pain management. So, whoops, I just wanted my pointer and then it went forward. So those receptors are in place. When an individual ingests other opiates, they're able to work on that opioid receptor. But they're way more potent than any of the chemicals that you have in your brain naturally. So you get a much bigger response and action than what we would get without them there. What naloxone is going to do is it's actually going to bump off any of those opioids. So I use fentanyl as an example. So fentanyl acts on those opioid receptors. We get big action. So it's causing all kinds of effects. When the naloxone is administered, it's able to kick off the fentanyl, and then you're not getting those effects. And unfortunately for the patients, that means that they may start going into withdrawal. These effects can happen within moments, usually within minutes, especially with the intranasal naloxone. And all of those actions, the pain relief, the euphoria, some of the sedation, things that maybe that they were using the opioids for, trying to take the edge off their withdrawal, are no longer able to happen. They are woken up relatively abruptly, so their consciousness returns, and they may start having pretty significant effects because their body is used to having the opioids on board. Some of the clinical trials we're going to talk about in just a minute had interviews with patients who use opioids, and their description of being administered naloxone tended to be really colorful. That they were relatively distressed. Some of them get very angry as soon as they wake up. And because they are so uncomfortable the second they wake up, that may make them not necessarily the most pleasant individuals overall. So why would we do this to somebody? It's relatively effective. I wanted to focus more on the pre-hospital administration of naloxone, so not what happens in the hospital. So does it work even though we make these folks uncomfortable? Absolutely. So these authors looked at more than 1,000 different articles, but they wanted specific information. So they ended up whittling it down to only 6. And they were comparing intranasal naloxone with IM or IV naloxone. So they really were worried about can the public, the lay public, use the intranasal, and are they getting the same outcomes? The outcome they were looking at was therapeutic success. So did the patient wake up, and did their breathing be restored? And what they found was more than 80% of individuals with suspected opioid overdose were successfully treated with the naloxone. So yes, even though it makes them uncomfortable, it is able to be relatively successful to at least wake them up so they're able to breathe and they're not in a potentially fatal situation. So if it's life-saving, if this can be that beneficial in at least 80% of the patients, why is this not rolling out way more robustly? Well, perspectives. That's one of the reasons that's been identified as a massive obstacle. One of the first reports was an assessment that was done looking at social media posts. So this was back in the day when Twitter was Twitter. And they were looking at posts about naloxone, and they were able to identify a number of the users. They looked at healthcare professionals only. They looked at those who were EMTs in law enforcement. There were nurses, physicians, pharmacists, pharmacy technicians, social work counselors. And they found 467 posts by 368 individuals that were able to be identified that had one of those careers. And they found of those posts, there were a handful of themes that were relatively common. Of the most common themes for the individuals who posted and had optimism and were really trying to promote and provide education and information, they had the lowest number of posts that reflected they were burnt out or had stigma toward patients with opioid use disorder. Those that tended to post more about greater burnout, fatigue, and stigma tended to be EMTs and paramedics. They were combined together, nurses and physicians. And one of the things that was common that came up were some issues and concerns with the use or repeated use of naloxone. Now, this was just looking at one social media evaluation. So have we done other research? Yes. This was done once naloxone was available in Mississippi. So law enforcement officers, firefighters, and paramedics were given a training by an independent pharmacy in one county in Mississippi, because this was just as they were starting to be able to carry and utilize the naloxone. So they gave them two evaluations, a knowledge evaluation and a perception evaluation, before they did the training and then after the training. You can see a number of the perception questions that are listed there. There were a few changes. So from the beginning to the end, they saw an improvement in the number of patients, or how strongly the respondents agreed to the fact that as a first responder, they have an important role in combating opioid overdose. There was a shift in, as a first responder in this community, I believe I can provide life-saving medical assistance to citizens with possible opioid overdose. So seeing that they're more empowered to assist with that, and then they felt more comfortable with it. So their belief that further training isn't necessary. So it showed that initially there was a little bit of hesitation and reluctance to how much of a role the naloxone could play. But after just the 1 hour training, they did see a shift where those individuals did feel more empowered and that naloxone should be playing a role. So is that the only information we have? There was an epidemiological study. So they did a whole bunch of interviews with individuals who use opioids as well as first responders. And as they were collecting information about the use of naloxone, they found that from folks who use opioids, there was a significant lack of trust with their healthcare professionals, lack of trust with law enforcement. They were afraid to call for assistance, especially if they had used naloxone, thinking it would cast suspicion on them for, why do you even have naloxone? That would only be something that an individual with a substance use disorder would have. And they were worried about the stigma overall of being seen having it or having to ask for it. On the first responder side, the themes that came out was relatively strong, so that naloxone can enable opioid use, that individuals are using more opioids, that they're taking greater risks because they feel that there's a safety net now in place with the naloxone. And there also was a theme that was one of the lesser themes, but it was that it doesn't address the underlying problem. And this one was my favorite, because if you think about what naloxone does, it's not supposed to fix the problem. It's just supposed to get them out of danger. It's supposed to be for emergency use only. So if the expectation is that this is going to change behavior and magically have individuals no longer misusing substances, that's not what it's been designed to do. So the quote from that particular study was that Narcan's been billed as a miracle drug. I agree. And when the timing's right, it is a miracle drug. However, it doesn't help everybody, and it will do nothing for you in the long term. It's a short-term fix, unfortunately, for a very long-term problem. So if there's a perception issue, some concerns about robustly using naloxone, does that make an impact? Does that make an impact on how often we're providing this life-saving treatment? That's where stigma comes in. So stigma is defined by these authors in the Journal of Pharmacy Practice as when elements of labeling, stereotyping, separation, status loss, and discrimination occur in a power situation that allows the components to unfold. So essentially, there's going to be differences or a loss of things like status, that labels are going to be applied when a certain situation is identified. There are a lot of examples of stigma related to naloxone. These were the top ones: that only illicit drug users or abusers are at risk for overdose. No, anyone who's using opioids, especially if they're using combinations, may be at risk. But that second one, the belief that naloxone enables risky behavior, seems to be one of the primary concerns, especially for individuals who are first responders. So just because that's a concern, does it actually impact how often we're using naloxone? The answer is yes. So these are two studies that look specifically at naloxone. So the first one was an observational cross-sectional study. So they did an evaluation of 252 participants in Pennsylvania, including a number of individuals who were first responders. They classified the responses into 4 different categories based on how much they agreed with stigmatizing statements. Those that were classified as having high stigma were the least likely to support things like naloxone distribution, including approving things that would completely get rid of it or institute more barriers to access. They also, interestingly, were opposed to any other type of harm reduction strategy. The other study, it was a semi-structured interview. So this was an interview that was done with individuals who use opioids as well as first responders. And they found that there were 4 themes that came up. The way to improve access was to assist with the stigma, increase public awareness. There were suggestions to have murals and public health announcements and things that made it so everyone had naloxone, not just those individuals who may be at risk. But the barriers that they saw currently were the fact that it wasn't available. Not all of the healthcare professionals would provide it, that there was an issue if somebody was seen with it, both by medical personnel as well as by law enforcement, that there was a lack of community support. There were a lot of places, including pharmacies, that didn't want to stock naloxone because they're hoping not to attract that crowd. So despite the fact that there is a possibility, there really are some structural, perceptional, stigmatizing barriers that are in place for getting this to roll out. It's a life-saving medication. That could be a massive problem, but it's not the solution to opioid use disorder. So does this have an impact on what eventually happens with long-term treatment, getting folks in treatment? So this was a cross-sectional study that was done that included law enforcement and then EMT and paramedic students. And they looked at their perceptions related to medication-assisted treatment, so methadone, Suboxone, naltrexone, for the treatment of opioid use disorder. And then they also asked a whole bunch of questions related to perceptions and stigma, both related to opioid use disorder and to naloxone. What they found, so there were a handful of results that are here. There are a couple that were a little bit concerning. So medication-assisted treatment being ineffective for reducing overdoses, about 40% thought that it would be ineffective for reducing overdoses. 55% thought it wouldn't have an impact on crime. 51% thought it would put more drugs on the street. And that less than, so about a quarter of patients, there's somebody talking outside, sorry, I thought they were yelling at me. Less than a quarter of respondents thought that an individual needed MAT to get clean. So really kind of encouraging individuals to go cold turkey or to try to do it without assistance when we know that MAT increases the likelihood that they'll be able to prevent relapse or abstain for an extended period of time. So the parameters that were driving these results were individuals who had the strongest stigmatizing results. They believed that folks who were utilizing opioids were dangerous. They blamed them for their use. They believed that they were just trying to kill themselves and they should be allowed to do so and not rescued, and that they should be isolated from the rest of the community. So this suggests that that perception, that hesitation for the use of naloxone doesn't only prevent or result in barriers for allowing life-saving medication, it may actually get in the way with more long-term treatment for patients with opioid use disorder. So my take-home points, it is one of the life-saving medications, and those perceptions, many of those studies actually showed that after training and education, a lot of those perceptions tended to shift a bit away from believing that it needed to be less accessible and not utilized, but that belief is still there, and we see it robustly in a number of different populations and cohorts. But that could really impair treatment for these patients and make it and everyone's job a little bit more difficult to do. So with that, I'm done. I'm going to stop my share.